And before starting with the presentation per se, I would like to clarify in terms of a disclaimer. And this is not just a didactic lecture or anything else. This is just sharing ideas and sharing viewpoints. So feel free to interrupt and ask me question whenever you feel so. And I don't know how much I would be able to see the chat per se. So I am completely fine if you feel anything has to be clarified. Then and then it would be better, because there is no point in waiting till the end if you have not understood, or if you have any doubts or anything to be clarified at the initial part of the presentation. So I am completely fine with that. I am like to be interrupted and I like to be questioned. So there is no hard and fast rule as such. Uh, Other than that, and why I have a very bad habit of talking a little bit faster once I am into the content. So feel free to interrupt me and say slow down if I am not audible, or if there is any video or audio issues, anything else is there, please feel free. And I think Amar sir, you please let me know. So even if you get any suggestions or any
Yes, sir.
feedbacks from the chat, you can please let me know.
Okay,
Okay.
sir.
Yeah, without any delay, let's go to the presentation per se now. This correlational studies in physiotherapy. Before going into the actual content, I would like to. I have started with initial few two to three slides, which mentions about the research question and research designs per se. This may not be actually directly related to the content or the topic of today's webinar, but I feel this is the basic from which we have to go ahead. So, as we all know, any research which starts with a research question. So, whenever you get a research question, we can classify that research question into different types. What can be the what type of the research question it is? I have enumerated it. If the question is somewhat like what proportion of the population is newly diagnosed with that problem each year, if it is that was your research question, then the research question type would be like incidence. If it is like currently living, it is not about that year, but it is like all the more data of currently living with that problem, then it will be prevalence. As we all know, incidence and prevalence or this or the majorly epidemiological designs, where as physios we may be not be that much interested in knowing about these data per se. What is more interesting or more relevant to the physiotherapy professionals would be like what should be done to treat this problem. Therapy, we need to know about the efficacy of the therapy. So that type of question would be like therapy, and what is the likely outcome of this problem. This can be somewhat relevant to us, so that we can frame our therapy or a treatment protocol accordingly. So this type of research question can be termed as prognosis. Harm is the type where if there is any negative effects of an intervention. This is also somewhat related to us, if whether we are interested to know whether the whatever treatments we are offering does it have any harmful effect, because in medicine, do no harm is the first principle we have to follow. And last type is the etiology. What causes this problem? This is somewhat related to our today's webinar. So when you arrive at a research question, we can say like we can classify it what type of research question it is. Okay, once we had identified the research question per se, then we have to know from where we have to look for the evidence from. Whenever we say evidence pyramid, we always say that okay, like RCT or systematic reviews of RCT is the best thing, or it is the first and foremost thing and all. But we have to know that is for which research question. It is not that a systematic review of RCT is the answer for each and everything. So if your research question type is somewhat like your incidence or prevalences, then you have to look for evidences from surveys, cross-sectional studies, and cohort studies. As we all know, if it is about the therapy, then it is clinical trials. So we all, since we physios are more concerned about therapy, randomized control trials or clinical trials is the one where we will be looking our evidence for. And if it is of prognosis, then again clinical trials or cohort studies, because that will also cohort studies will see the patient for a longitudinally, so we can able to somewhat we can able to judge about the prognosis also. When it comes to harm or the harmful effects of the therapy, clinical trials, of course, because clinical trials is has to be mandatorily disclose the any harmful events which has been undergone, and as well as cohort studies and a case control can be used for that. For etiology, to determine a cause effect relationship, we need to have cohort studies and case control studies. I'm not going to further into the detail of how these studies are done. As this is not our crux of today's webinar presentation, so I'm just enumerating it. Whenever you are facing a research question, understand from where we have to look the evidence from. We have a clinical research. This is also one of the study, which is this one slide which I had purposely added because we have to know what are the different types. So there is some certain confusions like whether the study can be called as experimental study or observational study. These things are there. As physios, we used to think like if the therapy has to be there for 2 to 3 weeks, then only we consider it as an experimental design also. But for research purpose, if the investigator has assigned the exposures or has influenced anything, then it is an experimental study. It can be a one time, it can be for 4 weeks, or it can be for 2 weeks. So if the investigator had assigned the exposures, then it is an experimental study. And if there is a randomized allocation, we will know it is a randomized control trial. If there is no randomized control allocation, then we can say it as a non-randomized control trial. This is very simple as such. When we come to observational study is the one where the researcher doesn't influence anything. He just observes. That's why it is observational study. This can be done with a comparison group. If it is done with a comparison group, then we can call it as an analytical study. If there is no comparison group, for example, incidence or prevalence, you can't have a control group per se, right? So that would be a descriptive study. When there is a comparison group in analytical study, depends upon the direction, exposure and outcome. Exposure is the one which we are doubting or we are researching it to cause the outcome. Then as usually it is being said like smoking and lung cancer, for example. If we had started tracking, observing the individuals who are smoking on a longitudinally, and we had following it up whether they had developed cancer or not. Then if you do this way, exposure towards outcome, then it is a cohort study. In case control, those individuals who had already developed cancer, we track back retrospectively, and then we will see whether their smoking habit has an impact on this. This is what our case control study. When it comes to cross-sectional study, it is a one-time study design where we see the exposure and outcome at the same time. This is the basic clinical research algorithm. Now, when our today's topic is we are mostly towards the cross-sectional study designs. What does this cross-sectional study designs? As I have just mentioned, it examines the presence or absence of the disease and disease as well as the exposure at a particular point of time, at one point of time. This is also known as a frequency survey or prevalence study. The major thing to remember in this study design is it cannot ascertain the temporal relationship between the exposure and the effect. So we cannot able to determine whether A had caused towards the B or B or towards A. We won't be able to ascertain this temporal relationship or cause effect relationship with this study design. You may be wondering like why I had been talking about all these things, but nowhere it is the correlation word itself had come. Where does it come from? I had purposely kept the topic as to be correlational studies because very frequently we come across literatures from in physiotherapy where the study design is mentioned as correlational study design. Ideally, there is not a specific study design to be correlational study design. It is a cross-sectional study design. We have to understand that it is in that we are ascertaining the correlation between two variables. You can in cross-sectional study designs you can see prevalence, you can see incidences. Same way you can ascertain correlations also. And why it is very popular among physiotherapy professionals, at least at the undergraduate and UG postgraduate level, it is very easy to perform, because whenever we get this task of doing a research, the first thing which comes to mind is whether we have to go for assessment or intervention. Intervention is a lengthy process, so let's go towards the assessment, which is an easy way out. So we go for assessment. One time event we want it. One time, majorly we end up doing some correlational studies. There are let me explain certain technical or the statistical parts of this correlational study design before going into our interpretation and its clinical implications. As we all know, there are two types: there is parametric and non-parametric. If your variables is continuous, for example, let us consider you are doing a work balance score. If you are considering the entire score of that scale, and you had did a normality test and the normality has passed, which denotes normal distribution, then we will be using Pearson's correlation. If, for example, let us consider the same BBS score, but you had segregated the data into two groups, like followers and non-followers. It is just only two groups. Then this can be considered as a nominal data, and we have to use non-parametric tests. Or if you are classifying the BBS score into three types, like low fall risk, medium fall risk, and higher fall risk. If it is an ordinal type, then we can consider it as an ordinal data, and in these types we can consider Spearman correlation. Also, if you had taken a total score of BBS or something like a height, weight, etc., continuous data, which is continuous data, but if it is not normally distributed, then also we have to do Spearman correlation. I'm not going into the details of this, what is the formula for Pearson's correlation or Spearman correlation, because there are all the statistical softwares are available, and practically none of us are going to do it using formulas per se. So I think that is not of much our concern. What is our concern is, like, we'll know about the types and degrees of correlation. If you, with respect to correlational studies, there can be two types. Either it can be positively correlated or it can be negatively correlated. For example, if it is a negatively correlated, the value of correlation coefficient can be, which we call it as R value, can be somewhere between minus 0.1 to minus 1. If there is no correlation, the value would be 0. And if anything, any value between 0.1 to 1 would be considered as a positive correlation. Let me explain this. What is the positive correlation? If you are considering like two variables, and for example, age and balance score, if there is a negative correlation between these two variables, what does it mean? If as age increases, there seems to be a reduction of balance score in individuals. So this seems to be when one variable value increases, the other variable value decreases. This is called as negative correlation. When there is no correlation, it's simple. There is it doesn't mean whether this goes up or down. It has nothing to do with the second value. Same way, when there is a positive correlation. For example, let us consider an example between physical activity level and quality of life level. What does that mean? These two scores go hand in hand. When to an individual who has a higher value in a quality of life has higher value in physical activity level also. This is called as positive correlation. I think this is pretty much fair, and everyone, we are aware of it. Then if, we are interested in knowing about the degree of correlation also. Degree means how much the correlation is. So the degrees can be like, either it can be perfect correlation. Whether if it is +1, we can say it as a perfect positive correlation, and if it is -1 exactly, then we can call it as a perfect negative correlation. In physiotherapy, or I believe even in healthcare, anywhere we may not be able to get a perfect correlation per se. So, however, that is the value we have to know. Anywhere between 0.7 to 0.99, we'll call it as a high degree correlation. High degree, if it is of positive, then positive high degree or negative high degree correlation can be there. And any value between 0.33 to 0.3 to 0.69 can be considered as a moderate degree correlation. And anywhere between 0.1 to 0.29 can be considered as a low degree correlation. It can be either positive or negative. If the value is 0, that is pretty straightforward, and there is no correlation. Okay, this seems to be like very much compact, and this seems to be answers every question. But there is a common confusion among clinicians and even sometimes the physiotherapy students, where when there is in correlational studies, what is the need of p-value? Why we should see p-value in the first sense? Because R value gives us all the values. Then what is the role of p-value here? As we all know, any p-value that will denote whether the obtained value or obtained result is by chance or not. In correlation, whatever R value we get, it is because of chance or not. This is what a p-value will determine. So this acts as a qualifier for a R value. By this way, while interpreting correlational study design, p-value always comes before correlation coefficient value. Let me explain this with an example. We are doing a study and you got the R value to be 0.5, which will denote your moderate degree correlation. But you have to see whether the p-value is significant or not. If the p-value is significant, then we can ascertain that the correlation obtained can be moderate degree correlation. Let us see the second example where the R value is 0.7, which somewhat around high degree correlation. But when we look at the p-value, it is more than 0.05, which we usually consider. So in this case, irrespective of the R value, whether it is high degree correlation, since the p-value is not significant, which means the obtained result is maybe because of chance, that R value doesn't have any better meaning. Okay, am I clear till now? Amasa, do we have any questions till now?
No, sir, no questions yet.
Yeah, okay. I'm going ahead. So, when this seems to be again somewhat little bit fair enough, like yes, first let us see the p-value, and then let us see the R value. If p-value is significant, let us consider about the R values, and we can ascertain the degrees. So this everything seems to be pretty fine now. But you would have come across this terminology as confidence interval, which has been preferred, and p-values has been bashed in literatures and social media stuffs like that. Why does this happen, and what does confidence interval mean? Confidence interval, what are we talking about in this is whatever we are considering hearing is the confidence interval. Confidence interval is for the correlation coefficient. What does this confidence interval? Let me explain the concept of this confidence interval per se first. It denotes the generalizability of the result. What does it denote? What I am meaning as generalizability of the result is because we are doing a study in a certain population, and if the same study we will have this confusion in our mind, like I think we have a question before going into that. We have a question of this p-value with the examples, right?
There are two questions.
Yeah. I am not able to see the question fully. Do you feel that I have to answer it first and then go ahead, or is it fine?
As per yours, sir, I think p-value question is related with your previous slide.
Okay, then I will finish that
Yes.
first. Then, yeah. What was the question?
Any example with for p-value, the same concept?
Examples I am not getting as such per se. I have given the examples. That's what this example I had given it again. Where if you are getting, for example, let us consider you are doing a correlation study between posture and pain. You have considered as some posture scores at one as a one variable and the pain scores at the second variable, and you got the R value to be 0.7 and your p value to be 0.07, and you have kept the p value level at 0.05. Then at this point, whatever correlation, that high degree of correlation we got between these two variables, like posture and pain, may be because of chance, and it is that we cannot ascertain that it. This shows that it is not significant. So we may not be able to consider that 0.7 of our value to be of high degree correlation, because this value would have occurred because of chance. Um, um, did this clear the doubt, or is there anything else? The person who had asked the doubt, you can please unmute yourself and you can converse. We can converse directly. Okay.
And there is one more question,
Okay.
sir.
Thank you. Yes.
Any difference between measuring correlation and agreement?
Yes, we will come to that in the at the end of the, if at all it is not covered, if it is still there at the end of the till end of the presentation, we will see to that. Okay, because that may confuse the listeners now. Okay. So we will do one thing. I think it is if you feel any questions has to be answered then and there, you please let me know, so that I will not interrupt with the questions right now. Okay. If you feel any questions has to be addressed then and there, then I will address that question, or else we will keep it at the last. Okay.
Sure, sir.
Yeah. As we had come across this confidence interval. Confidence interval is a term which has been much more preferred than p-value. And what is that concept of confidence interval? This denotes the generalizability of the result. What does this generalizability of the result means? Whenever we read article, whenever we come across a study result, we have this doubt in our mind whether if the study is replicated again, whether it will fetch the same results or not. So the confidence interval will give values in a range, from a lower bound range to an upper bound range. In this context, confidence interval of correlation coefficient, matlab R value, it will give a values in the range. That what does that value means? If the study is being done at different populations, 95% of the time the results obtained will be within this range. So this gives a broader meaning to the p value. That for this purpose it is preferred over p value. As well as this does the value of p value, this does the work of p value, that is denoting significance. In addition, this denotes the variability also. I know this is a little bit confusing. Let me explain this with an example. Let us consider the first example of this one, where R value we are getting it as 0.5, which denotes a moderate degree correlation. Okay, but when we had calculated the confidence interval value, suppose if you are getting the value to be minus 0.5 to plus 0.7. This is the variability range. This shows that if the study is replicated, then there are chances the value we get can vary anywhere between minus 0.5 to plus 0.7. What does this denote us? This denote that the variability is too large. Above that, this crosses the mid value of no correlation value, which is 0. So this crosses from minus. So the value can be anywhere between minus or 0, or as well as plus. If such a confidence interval we get, where it can have a chance of falling in any of the three, then the p-value will be not significant. For this example, if we have calculated the p-value would have been more than 0.05, which is not significant. Same way, if you are taking the example of this, where R value is 0.2 again, which is a low degree correlation, still the confidence interval value will change from, if it changes from minus to plus, then again we can say for sure the p value would be non-significant. Okay, you may be asking this question like, okay, this can be even easily ascertained with R value and P value also. Why do we need a confidence interval? Let me give this example of where I have given this. R value is 0.6 and the confidence interval values ranges between somewhere between zero point 0.1 to zero point 0.8. Here, if we are doing only P value, it would have been significant. And the R value is zero point 0.6, which denotes moderate degree correlation. But since we have taken confidence interval value also, the lower bound value of the confidence interval is somewhat between 0.1, which denotes low degree correlation, which means if this study is replicated elsewhere, there are chances where we can get low degree correlation, moderate degree correlation also can be given. So what is being assured with this is only till 0.1. What can be an ideal correlation to get? So if we are getting an R value of 0.8 and the confidence interval to be like lower bound confidence interval to be 0.5, then we can say moderate degree correlation is ascertained at least in 95% of the time whenever we do this, replicate that study. Above of after saying all these things, we have to see for biases and as well as confounding variables. That is also there. Considering there is very less biases and there is no confounding variables present, we are talking about the interpretation here. Okay. So this is why confidence interval is preferred over p-value. When we come to this, we would have come across certain things like correlation, causation. Whenever there are studies about correlation, we would have been saying like correlation doesn't imply causation. These stuffs are there. And what does that mean and how it is relevant to our field? This is what our main crux of the today's webinar.
I think there's some connection issue and the connection lost from his side. Just let me see if we can get back. Yes, I think there were a lot of questions till then. Yes, he's back. Is it visible, sir? PowerPoint?
Yeah, for me it is visible. Okay. Sorry again. That's a bad technical glitch. Okay. When we are talking about correlation and causation, if we are considering some funny study like if you check the if you have correlated a study between those who had went to moon and their dietary habits, and if we can if there is a positive correlation between whoever had eaten chicken had gone to moon, we can come to the conclusion like chicken makes you to go to moon, which is absurd, we all know. So this is where the problem comes when we arrive at cause effect relationship between the two variables, which is meant for correlation, then these absurd interpretations may come in. This is where our principles of our physiotherapy principles, whether it is an assessment or whether it is in treatment things, have issues. Next slide, please. Okay, you may ask that then what is the how we can establish a cause effect relationship. To establish a cause effect relationship, we needs we requires longitudinal studies. As I had mentioned in the previous part of the presentation, I would have mentioned about for etiology we need cohort and case control studies, which is called as the which is longitudinal in nature. So we requires cohort or case control studies to establish a cause effect relationships, which can fetch us about effect size values like odds ratio or risk ratio, which determines what is the odds or risk of that exposure causing the effect or the outcome. So to establish a cause effect relationship, we require systematic review of longitudinal studies, which is stable and which gives us the consistent results. Next slide, please. I would like to quote this example as such. This was one of the very famous systematic review, which has been famously quoted and famously shared by everyone. Where in this, it was a in this systematic review, the researchers had done was had the question of whether the lumbar spine flexion is a probable risk factor for the low back pain. This is what their intention. This is what their research question. For that, they have screened the studies, and they had done some systematic meta-analysis, and then they had come to the conclusion that that lumbar spine flexion doesn't seems to have a major doesn't seem to have an impact on low back pain. This is what they had come up with. No matter as this is contrary to our traditional belief, and this has been very widely popularized and been done by very celebrated professionals from physiotherapy. It has been very widely shared and it has been published in journals like JOSPT also. But evidence doesn't see for your intention, it sees for the evidence per se. It is sees for the technicality and the procedures per se. The problem with this systematic review is they had in this out of 12 there is only one longitudinal study was done. Other than that, everything else was cross-sectional studies, which has been obviously it has been fairly mentioned there. But the problem is with only one longitudinal study and rest of them being cross-sectional studies, we cannot ascertain the cause-effect relationship, and we can't term it as a systematic review. What can be the results by this is, since it is majorly from a cross-sectional study, what we can say is we don't know the impact of spinal flexion to low back pain. This is what I have to say about whenever you come across a cause-effect relationship or determining a cause risk factor, you have to see for whether that study or a systematic review had taken longitudinal studies for consideration. There have been certain statistical tests which is available from cross-sectional study to extrapolate the cause effect stuffs, but that is really not possible because ideally we need to have a cross-sectional longitudinal studies either from exposure to outcome or retrospectively from outcome towards the exposure. Next slide, please. Some examples in physiotherapy where we seems to establish the cause effect relationship just because there is correlation seems to be present, like as I had already mentioned, like whether it is posture and pain or structural dysfunction and task, spasticity and movement, because all the almost majority of the patients with human lesions has spasticity, and they have movement issues also. In the same way, when it comes to disc bulge and back pain, we physios readily accept it, like that there cannot be a thing just because disc bulge is there. We need not to ascertain that to back pain. But within our profession, there seems to be a lot of things where we had assumed the cause effect relationship. Next slide, please. Okay, so to ascertain what can to implement something in our clinical practice, what are all the steps has to be done? Next, if you are doing a cross-sectional study, and if you find out there seems to be a fair amount of association between these two variables, and it is consistent among various studies suggested by systematic review of cross-sectional studies, then we have to go for longitudinal studies. Longitudinal studies to establish a cause-effect relationship. If the series of longitudinal studies had established, and we are convinced with that this variable, or there is a cause-effect relationship, this is causing that outcome, then what can we do is, then we have to define next. Then we have to define some treatment protocols. So that treatment efficacy had to be examined via RCTs. When the treatment is effective via RCTs, and that has to be next, then that has to be established via systematic reviews of RCTs, then we can say that treatment is effective for that problem, and that can be implemented in our practice. I know this can be a little bit confusing. Let me explain the same thing with the example. For example, as I have mentioned, if we believe, if we saw that posture and pain correlation is higher, and it is, if it is been consistent, what we can do is we can do a longitudinal study to establish a cause-effect relationship, to know whether majority of the patients who had a we have to track the patients who had posture, and we have to track down and see how many number of patients had developed pain, back pain, or any pain per se, and who had not developed pain. If we come to know, then only a considerable amount of persons had developed pain, then only we can ascertain that posture had caused the pain. Again, I am saying this has to be seen to that all the other biases and as well as the confounding variables has to be taken care of. Considering all this has been taken care of, then we can consider the cause-effect relationship. If it is established, then we have to do, then we have to frame a treatment program. For example, postural correction exercises or postural corrective devices, anything else. Then that efficacy of those techniques or those interventions has to be tested via RCTs. It is not only a single RCTs, and then if it is been done by a systematic review of several RCTs, and it is been, the efficacy had been proved, then the implementation of postural correction exercises for pain relieving can be implemented can be implemented in the practice. The problem what is happening, which seems to be happening in my point of view in our profession, is we had seen some correlation between posture and pain, and we had bypassed the second step, and we have bypassed the third step, and we have directly implemented in practice, considering posture had caused the pain, and postural correction exercises, postural correction intervention will correct the posture, and thereby it will improve the pain. This is what we have implemented. This is why whenever we are discussing, whenever there is a critical review on posture and pain correlation, people are not just in favor of this. It is not, when people are asking for the evidences, it is all these processes they are being expecting. It is not just a systematic review or some meta-analysis per se. Next. Okay, having said all these things, you might be wondering, like, why, if correlation study doesn't have much impact, then why such a study doesn't exist in the first place? Because correlation study is a thing where it can be considered as an entry level screening from physiotherapy point of view, where you can see there can be n number of variables which can seems to be associated with one another. We can't afford to put our time and research resources to determine the cause-effect relationship of all those variables. First of all, we want to see whether there is any association at all between these two variables. If there is association which has been consistent among various studies, then we have to go for cause-effect relationship, establishing a cause-effect relationship. If there is, for example, if there is no correlation at all, then we need not to bother about cause-effect relationship. So this correlational studies can act as an entry-level screening and not as a anything which has to be to do directly with your clinical practice per se. Next slide. Yeah. So whenever some people or those who are in favor of evidence-based practice says demand evidence, it is not just some papers from Cochrane Library or papers in Cochrane Library or some other high journals. It is not some data. It is the process where we have to understand. First of all, if someone says something, we have to see for the biological plausibility. Our professional knowledge is very essential for this. If someone comes and says if you can mobilize your skull with minute manipulation skills, or we can manipulate your viscera with your hands, all these things, the first question you should ask is not about the RCT showing the effect, but the biological possibility in the first place. Whether is it really possible? Our knowledge of our understanding of human physiology, human biology has a greater role in this, because we can't just waste the resources of evidences in ascertaining something which is not plausible in the first place itself. Okay, once you have convinced that that is biologically plausible, then you have to see for whether there is an established cause-effect relationship has been there. And then even if it is there, if you feel that it is already been established, then you have to ask for the proved efficacy of interventions. Before implementing something in our clinical practice, we have to demand all these things. In physiotherapy, we are relatively a newer profession to healthcare when compared to medicine per se. So we may be lacking in all these steps. That's why many of the evidences in physiotherapy profession per se has lesser evidences or unclear evidences. It is because of this. Sometimes we professionals get disheartened by this, saying like there is nothing is certain in evidence, what can be done, because it is a process and we are evolving, and we will come to that stage where we will be able to provide better evidences if we follow all these steps. I hope so. Next slide. So my take-home message from this presentation per se is cross-sectional studies have less value in physiotherapy practice, clinical practice per se. And as mentioned, it is the correlation doesn't mean causation. It can be causation also. I am saying that, but it doesn't mean causation also. It can be coincidence too. Always remember that correlation can be coincidence too. So many of the time, many of the issues in physiotherapy practice seems to be very logical, and we because we that is the way we have been trained and we have been taught and we have been teaching. So that logical doesn't mean physiological. Human biology is adaptable to great extent, and we are yet to understand human biology yet. So we really don't know to fuller extent of how human biology reacts to various adaptations. And finally, I want to say we don't know much, and that's fine. That's okay. We are evolving, and we will be able to know little by little more. Next slide, please. As famous statistician Doug Altman says, we need less research, better research, and research done for better reasons. Thank you. Any questions are welcome. Oh, shit. I had left on this. Hello?
Yes, sir, you are visible and audible.
Yeah. Do we have any questions or anything else which has to be clarified?
Okay, we have few questions. I think the participant can unmute and ask. I think that will be a little more.
Yes, that would be better. I think
It will give a little more
that would
clarity
be.
to the question.
Yes.
Okay, we have questions from. Let's start from where. Okay.
Yes.
First question was, what is the difference between measuring correlation and agreement?
Agreement can be of in any times. Like my understanding of agreement is like it can be even in inter-rater reliability also we can see for agreements like how much it is the values which has been obtained is an agreement with that. And correlation is somewhat how much whether is there is any association. Correlation means whether is there is any association between these two variables or not. It's simple as that.
Okay. Then we have a question, I think, by uh, Munazza Uruj. Yes. She's saying if she has done a study on impact of COVID-19 pandemic on quality of life and medication adherence. What will be the study design for this? Observational or
No, what,
cross-sectional study?
no. What is the impact of
COVID-19 pandemic on quality of life and
yes.
medication adherence among TB patients.
Among TB patients, this will again is simple. If it is, we are thinking in terms of etiology, right? Then again, it is an etiological question where we are seeing like whether this had caused that, and whether the COVID pandemic had worked as a risk factor or a causative factor to cause this adherence or quality of life deterioration or enhancement, whatever it is. Then it has to be a observational study per se because we are not intervening anything. We are just interested in knowing the relationship between that. It would be an observational study, but it has to be a longitudinal study to determine the cause effect relationship or risk factor analysis.
Okay. Uh, Fine. Now then there is a, I think, uh, question like from David Poulter is, can you tell something about efficacy and effectiveness in study design?
Efficacy and effectiveness in study design. I'm not able to say that. Maybe I'm not. I'm unaware of it. Yeah, I don't know.
Okay, then other thing was maybe I think that's the questions. Okay. Uh, One more question is there. Explain about what is pilot study design um, with examples. Some examples.
Pilot study is not a. It can't be a study design per se. Pilot study in short, it is just like uh, before doing if you are before doing an entire study, if you're doing at a smaller scale, the reasons for doing a pilot study can be various. If you are not able to, majorly it has been done in terms of to calculate the sample size. If to calculate the sample size to establish at the whatever outcomes you have taken to determining the if you are determining the power of the study, so in that case you may do a pilot study. Pilot study is not a research design in itself per se. It is a preliminary one before doing actual study, and to make it more effective in terms of power or the sample sizes, we can do a pilot study. We can't consider pilot study as a separate study design in itself.
Right.
And we have to always remember the pilot study is being done for certain reasons that has to be taken care of with that, because we usually say like because we usually say like we publish pilot studies per se, and we thinking that can have some implications on clinical practice. I personally believe that pilot study cannot infer anything to your clinical practice per se, because the intention of doing a pilot study is to do the full longer study or the actual study. Then that is the purpose of that. If you have done that, it can't give you anything directly to your clinical practice. Yeah.
Right. Then we have again a point by David. Correlation cannot imply causation. In an RCT, one needs a control group to speak to a causation effect.
Yes. That's why I in the clinical research algorithm I had mentioned, if whether if even if it is an, there has to be a control group to term it as an analytical study design. Otherwise, if there is no control group, it will be considered as only a descriptive study design. Why? Because there can be four factors playing in any research design. Whether it can be a chance, by the whatever result we are getting in that study, it can be because of chance. That can be taken care by statistic, which is our p-value. Second is bias. It can be any number of biases are there. So biases has to be taken care of with if it is an RCT, then that will be taken care of by n number of like randomized allocations and blinding of the outcome assessors. All these things can be taken care of. And thirdly, that can be confounding variables. Confounding stuffs can be there, which can be taken care of by having a rigid study design per se. That is where your professional knowledge is required. And if you are having a very good study design, confounding variables can be taken care of. And fourth can be the actual cause effect relationship. So to determine the this treatment had caused that effect, we need to rule out the first three factors, that is because of chance, that whether it is because of bias, or whether it is because of any confounding variables. If we had nullified these three to certain extent, you can't nullify bias to greater extent. So it can be like, if the biases are less, if the confounding variables are taken care of to a greater extent, and the chance factor has been taken care of, then we can say that the effect obtained is by maybe because most probably because of the therapy.
Right. Okay. Again, a question on R value and P value.
Again, R value and P value, to put it very simple, whenever you are seeing a correlation study, first check for the P value. If it is significant, then check about the R value. This is very, if I have to keep it very simple with this, it is only this. It is not that since we have R value, we can ignore the P value. There are certain studies which highlighted the R value, but when we had seen for the P value, it would have been non-significant. If the P value is not significant, R value doesn't have much meaning, because the first step of chance in itself has been nullified.
Okay, so if P value is not significant, then there is no point of R value.
R value, because you may get a higher correlation also, but what does that higher correlation mean? That would have occurred because of chance.
Right.
And that's why rather than going for P value, you have to go for confidence interval, which clearly will shows from minus to plus. So what is the whole point of
Yes,
that
exactly.
R value? It is not there.
No,
Yes.
no point of it. Yes, exactly.
No point of that.
Then another question is kindly explain again about what is a cross-sectional study and longitudinal study.
Okay. Cross-sectional study is a study which is done at only one point of time. For example, you had done a study which is like you will be assessing patient at only one time. Let us keep it very simple. You are assessing patient at one point of time, and you are seeing all the variables. For example, if you are assessing the patient, the pain patient, okay, you are assessing the pain score, you are assessing the postural score, whatever it is, you are assessing the patient at only one point of time. Then it is a cross-sectional study. Cross-section at that one point of time. Okay. Whereas longitudinal study is you are following it up with the patient. Whether if the patient comes with a if you are screened 10 people and 10 people had poor posture, you are following it up with them. like seeing at regular intervals after 1 month, after 1 year, if you are seeing it up there them and you are checking whether they had developed any pain, and that pain also can be whether it is because of this. That's why you need to have a control group also. Control group in the sense you have to make a 2 by 2 table where how many people had poor posture and how many had got pain, and how many people doesn't have poor posture, they also would have got pain, there are chances are there. Then we have to establish the odds ratio or risk ratio to ascertain the cause effect relationship. Simple, to keep it simple, cross sectional studies will be done at only one, you will be assessing the patient only one time. This is at a periods of time. Longitudinal study will be, you will be assessing it. Yeah.
Okay, we have one more question by
Yeah.
David. Yes. How
Yes.
do we control for clinical equipoise affecting outcomes?
How do we control for clinical non-equipoise? I am not getting the question. Do you understand the question? If it is there, then you can please explain it to me. I'm not understanding the question itself in the first place.
Okay.
If you can able to explain it a little bit, if you understood it, then I would be able to know. I will be able to say it.
Okay. Then we have one more question. How do we comment on confidence intervals?
How do we comment on confidence intervals? Okay. See, the confidence interval is lesser the better. If the value is lesser, it is more better. If the value crosses the zero or the mid value, why I'm saying mid value is the confidence interval concept is for any other effect size values also. For R value, if you are seeing a confidence interval, if it crosses the zero, I understand that it is non-significant. Even though if it is not crossing the zero value, but it, as I had mentioned in the third example, if the value is somewhere between 0.1 to 0.9, then you can understand that it is the chances are low degree, high degree, moderate degree, anything can be there. So the variability is more. Always see for the lower bound value of the confidence interval, which is the sure shot thing. At least this is for sure you have to get it even if you are doing it in your population also. So
Exactly.
confidence interval smaller the better, and the lower bound value, if it is higher, then it is more better.
Okay. I think that's all the questions, I guess. Any other questions? Anyone? Okay, David has an answer for me.
I think clinical equipoise speaks to the belief of the therapist applying the therapy in a trial. If I believe the intervention will work, I have non-equipoise, and this will affect outcome versus if I have equipoise. Yes. So how do we control for non-equipoise affecting outcomes? Okay. How do we? Blinding of the people who are assessing the outcomes can be the thing which can have this impact of because obviously in PGs, in PG level research, or even in higher level research is also, we don't have a different person for assessing the outcomes per se. Blinding will do this for, I feel blinding will do this because the way if it is like any objective scores, if it is not a mission where we will get is like a authentic for example, if it is of height, I can't be that much biased about it. Whereas if it is a balance score, if I am, for example, I am assessing work balance score, if I know if that person is a experimental group patient, then I would start thinking whether most probably this is not 2, this is 3. The same thing for a control group, I would start thinking this is not 2, this is 1. This may happen, and we are humans, and we have to be we are biased, and I don't think there is no way we can eliminate the bias completely. That's why we always say for less bias, less likely, or more biases are there. High risk of bias or low risk of bias. I think blinding will do that.
Right, exactly. I think equipoise studies we see a lot in manual therapy studies. Okay, again, I'm biased about
Yes,
that.
yes, yes.
Yes.
Yes, and the thing is, like, I mean, there has been one common arguments with these manual therapies or in stuff like neuro techniques, where it's like you can't the people who is blinded cannot assess it properly. They will not be able to appreciate it. All those things. The same way, if I am doing the therapy, I would obviously it is a challenge to my technique and my expertise. So I will be always grading myself more. I think we can't help it. That's how research works, and we have to follow it up.
So,
Unless until we become the PK, Amir Khan of PK, then we can't. We will be biased only.
yes, exactly. Okay, sir, does experience have any role in terms of your means, in terms of neuro techniques? Means
See, in
if
any technique, experience has an impact. See, but why I am saying experience has an impact is where how to convey it to the patient, how to talk to the patient. Everything comes from experience. See, I am also like somewhat. This has come to that conclusion, like where experience is not needed. People started thinking like evidence-based practice is something against experience one. No, that is not true. Experience is what when it comes when we can understand the patients better, even the way you are talking to it. For example, I can say my own example. When I had during my student time, whenever my patient says like my what is your was, and I used to explain like same thing, NRS like zero matlab no pain, and if 10 is high pain. Most of the time patients used to say that it is 9 or 10, and the moment they go out or when they take the phone and they talk, when they talk happily, I used to talk to my colleagues and to say that he is having 10 pain and see how he is laughing. This is what, if we are taking it, but over the time I understand that it is not the pain intensity, it is the um, uh, perception of the pain. You may think this is very basic, but we have to understand, and I think these simple things, communication steps, all these things comes over experience. So obviously experience has a role to play, but the way we deliver also has a role to play. And on the other hand, contrary, research studies have shown like where experienced people are more tough to change their beliefs. So if it is when it comes to efficacy of the treatment per se, experienced people may have very strong biases. That is also there. So we can't help it. We
yes,
are humans, and it has
yes,
to be there.
yes. But there is an argument. Like yesterday, someone was telling me. So in the
Yes.
study, the therapist didn't had experience to deliver dry needling. So that is why he said I cannot
Okay.
believe on this study. So I was thinking like how much uh,
Mm,
is that?
Then we have to. Then is there a criteria to say that dry needling would be effective only if it is being done by people of this experience? Are we going to say that that is the case, no one can gain that experience? Then I think this is all the things which is always be there. Those techniques which has biological plausibility questionable, efficacy questionable, biases high, will always have this kind of arguments.
Yes, exactly. Okay, I think that's all the questions. If anybody has anything else to say, we can end. Yes, any other questions anybody wants
We got
to?
a question. Let's see.
I think
I
this.
basically,
Oh yes. How to write systematic reviews and meta-analysis. A session on that.
I may not be a proper person because I myself have not written anything. There is, however, I have been training for it. I have been going on for that. Those things. I don't think I would be the appropriate person to take such a session. Maybe
Yes, exactly. We would like to have a
that
session
can be
by you on some neuro topics, sir. I think
neuro topics. Yes, that would be good. We'll
yes.
see. We'll see in future for sure.
Thank you, thank you. Anybody has anything to say, or we can. Uh,
How to implement research evidences like either from systematic reviews or any RCTs in our clinical practice? What is our suggestions on that, sir? How to implement research evidences like this either from systematic review or any RCTs in our practice? For clinical practice, keep it very simple. Like no one systematic review, sorry, no one RCT can change your clinical practice. So that is not for it has been meant for. And obviously, it has to be systematic reviews. Now, systematic reviews also it has been done at various places, and various systematic reviews has also been polarized, and it has been predatory stuffs have been pitched in that also. So go for some authentic stuffs like Cochrane, or there are Cochrane clinical answers are there, which give you the direct clinical implications. But unfortunately, from for India, it is a subscription one. We may not be have to have that accessible to it. However, plain language summary is available in Cochrane, which is free of cost for everyone. Anyone can access it. That would be the thing where we can go for it. Why I am saying Cochrane is, you can ask whether Cochrane is there, because Cochrane is the one organization where they had given so much of checks between when it is been printed. If it has been printed in Cochrane, we can say for sure it has been checked. However, there can also be chances of biases and chances of false information probably may be there, but it is less likely there. So go for systematic reviews or meta-analysis from authentic sources like Cochrane Library. That is my simple advice.
Yes, exactly. Nowadays we are having garbage in and garbage coming is out as systematic.
Yes.
Exactly. Okay, I think, sir, that's all. I think there are no more questions left.
Okay.
Yes, any other?
Thank you, Mama sir, and the team for giving me this opportunity. And really sorry for those technical glitches. I don't know. All of the sudden, today is the day everything had happened.
Yes,
Okay.
it always happens on the day of session.
Yes.
Yes, exactly. Okay, thank you, participants. Thank you to the sir for taking up a session. I think we can keep up more sessions like this. This is just a platform for exchanging knowledge, and we are all here to just exchange knowledge. Right. Thank you, sir. Thank you so much.
Thank you, Amit. Thank you.